Good morning, ladies and gentlemen. The topic of today's lecture is very important because methotrexate is one of the most common anti-cancer or anti-inflammatory drug that is used in dermatology with years of experience. So today we are going to discuss the role of methotrexate in dermatological illnesses, and all about the methotrexate monitoring and toxicity. I am Professor Asher Ahmed Mashood, and if you are hearing to my voice, please subscribe to my channel. What is methotrexate? Methotrexate is an anti-cancer medication which is used in low doses to treat inflammatory conditions such as psoriasis or eczema. So, in high doses, it's an anti-cancer drug, and in low doses, it's an anti-inflammatory drug. So, there will be a time when patients will ask you that, Dr. Saab, you have prescribed me an anti-cancer drug. So, this should be the answer that this drug, in the doses in which I am prescribing you, it is anti-inflammatory and not anti-cancer. The drug is commonly prescribed in rheumatoid arthritis, in psoriatic arthritis, and in other inflammatory and autoimmune disorders, which are, of course, off-label use. In high doses, it is used as a chemotherapeutic agent for treatment of leukemia and other forms of cancer. Methotrexate can be given to children but not lesser than 3 years of age and can be freely given to adult patients. How does methotrexate work? Methotrexate is a structure analog of folic acid and is a potent competitive inhibitor of dihydrofolate reductase, which converts folic acid to tetrahydrofolate. So methotrexate at low dose has immune modulatory effect. It reduces the homing of T cells in the skin, and most of the inflammatory conditions are initiated by these homing T cells. It also reduces the oxidative inflammation in neutrophils and monocytes or macrophages, and also inhibit the cytokine release from monocytes, macrophages, and decrease tumor necrotic factor alpha, interleukin 10, and interleukin 12, which are the main cytokines involved in eczema and psoriasis. At higher anti-cancer dose, methotrexate acts more as an anti-metabolite. This means that it reduces the speed that the skin cells proliferate because it antagonizes the B vitamin and folic acid. And hence it reduces pyrimidine, purine, and methylation of DNA. So all these effects results in decrease in cellular proliferation. Indications. Methotrexate is generally or most commonly used in psoriasis, generalized psoriasis, in pustular psoriasis, and in psoriatic arthritis. It is also prescribed in severe atopic dermatitis, SLE, and dermatomyositis. Also used in cutaneous sarcoidosis along with steroids. Is prescribed also in PRP, although pityriasis rubra pilaris, the drug of choice is retinoids. Is also prescribed in Pomfilix and other chronic hand dermatitis. Methotrexate is given in PLC or in pleva, in chronic spontaneous urticaria when nothing is working, in immunobullous disorders like pemphigus and pemphigoid, but definitely the treatment, it's not treatment of first choice. If we are going to give some steroid sparing agent, then preferable is azathioprine or mycophenolate mofetil. Then it is good in morphia or even in systemic sclerosis because it is antifibrinolytic. Then it is given in severe generalized lichen planus or erosive lichen planus. How quickly does the skin condition improve on methotrexate? You should know all because many a time we have observed that patient usually take the medicine only for 4 weeks, and you have to tell the patients that this is how much time the methotrexate will take for its effect, and whatever effect you will observe in first 4 weeks will mainly be due to the topical preparations which are given along with the methotrexate. So it starts its benefit in skin diseases in 6 to 8 weeks, and always tell your patient that you have to take the drug at least for 3 months. Maximum effect is generally achieved within 5 to 6 months, depending upon the dose escalation. In one study, reported that PASI 75, that means 75 reduction in PASI score at week 16 in 41% of the patients who are treated with 17.5 or 22.5 mg per week. Dosage. The typical dose of methotrexate range from 7.5 milligram to 25 milligram once a week. It is usually started with 5 to 10 mg weekly and increased by 2.5 to 5 mg every 2 to 6 weeks until the disease gets stabilized. Methotrexate is available as 2.5 mg tablet or 10 mg tablet, and also as a solution which says 50 milligram in 2 ml. It is better not to mix the 2.5 mg and 10 mg tablet because this will result sometime in overdose. Folic acid is always combined with methotrexate. The dose is 5 milligram once a week, but not on the same day as methotrexate. Folic acid will reduce the methotrexate side effect, but if you give folic acid more often, that is, I have seen some doctors prescribing folic acid for 6 days and only leaving it on the day methotrexate is taken. So if high dose of folic acid is taken, then it will compromise the anti-inflammatory effects of methotrexate. So once a week, folic acid is sufficient to reduce the side effects of methotrexate. Contraindications and cautions. For pregnancy and breastfeeding, it is absolutely contraindicated. For suspected systemic or local infections, it is relatively contraindicated. In bone marrow failures and unexplained anemia and cytopenia, it's absolutely contraindicated. Then in significant renal impairment from any cause, use with caution. In localized or systemic infection, including hepatitis B or C and history of tuberculosis, use with caution. And with concurrent antifolate drugs like trimethoprim, it is contraindicated due to potential of bone marrow failure. What about methotrexate in pregnancy? Methotrexate is categorized as pregnancy X drug. At higher doses, methotrexate is known to cause miscarriage or stillbirth, especially in first 3 months of pregnancy. And in obstetric wards, methotrexate high dose is used to induce labor. There is also a concern regarding the risk of low dose methotrexate affecting the functional development at later stages of pregnancy. It is therefore recommended that pregnant women should not take methotrexate, and women of childbearing age should not become pregnant while on methotrexate and should stop the drug at least 3 months before trying to become pregnant. Adequate contraceptive measures are necessary during methotrexate therapy. What about breastfeeding? The amount of methotrexate excreted in breast milk is likely to be small. It's unclear how much it would be absorbed in the nursing baby. However, the precautionary approach is to limit or avoid breastfeeding in mothers on methotrexate therapy. Then what about the father? For many years, men were advised not to father children while they are on methotrexate or for at least 3 months after stopping the drug because methotrexate has reported to cause reduction in the sperm count. But the current expert view is that the risks are very low and this precautionary approach is unnecessary. So I am saying that if a person is on methotrexate, there is no harm for him to become a father. Other health concerns. Care should be taken while prescribed methotrexate in patients with known anemia, leukopenia, or thrombocytopenia. It is unsuitable for patients with severe liver disease and should be taken with caution with patients with significant liver or kidney disease, infections, obesity, and diabetes, particularly in metabolic syndromes. The illnesses can increase level of methotrexate. Dehydration from fever, vomiting, and diarrhea, or decreased fluid intake may increase methotrexate level and cause toxicity. So, excessive thirst is an indication of dehydration. Stop the drug immediately and check the methotrexate levels. Dehydration or any other reason is there any is other reasons to reduce kidney function may prevent the normal excretion of methotrexate, resulting in toxic accumulation of the drug. And this excessive methotrexate can in turn damage the kidneys further. Alcohol and methotrexate. The alcoholic beverages, including beer and wine, may increase some of the side effects, which include the chances of inducing liver damage. So, the patients on methotrexate should limit their alcohol intake to less than 20 gram a day, that is 1 to 2 standard drinks per day, 10 to 14 drinks per week. How to take methotrexate? Methotrexate is taken weekly and not daily. The importance of this weekly schedule cannot be stressed enough. It is best if a specific day of week is nominated, for example, Monday, on the prescription. So write that you would take methotrexate on this day, and also to tell the patient that if you forget to take the methotrexate on the specific day, then take it on the next day. So the patient should not assume that he has to take the drug only on that specified day. On the specific day of the week, methotrexate can be taken as a single dose. For example, if you are prescribed 10 mg or 15 mg, then the patient will take 1 or 1.5 tablet stat, or it can be given in 2 to 3 smaller doses. That is, if you are giving, say, 15 milligram, you can give 10 mg in the morning and 2.5 mg in the evening, or vice versa. If methotrexate tablet cause nausea, your doctor may recommend splitting of the dose, that is, taking after meal or at bedtime 2 days a week. For example, if you have prescribed 10 mg methotrexate weekly and the patient is having nausea, then you can give half tablet on one night and half tablet on the subsequent night. If oral treatment causes too much gastrointestinal side effect, once a week subcutaneous injection may be tried, which is generally well tolerated. As I've told you, the the injection form of methotrexate contains 50 milligram drug in 2 ml. So 1 ml will contain 25 mg, and if you have to give, say, about 15 milligram, you can take half ml, or you can reduce further according to the dose which is to be prescribed. And this dose is given subcutaneously or intramuscularly. Taking methotrexate more often or changing the dose schedule may result in serious side effects. So always instruct the patient not to change the dose schedule, or don't overdose it, and explain the patient in very explicit manner then the drug has to be taken weekly. Monitoring schedule. The pre-treatment assessment include complete blood count, renal function test, liver function test, chest x-ray, unless the chest x-ray is done in previous 6 months. Pulmonary function test may be advised in selected patients. Then monitoring of blood count, liver and renal function is done 2 weekly until the dose of methotrexate is stabilized for 6 weeks, and then monthly until the dose is stable for 1 year. Thereafter, the monitoring is done based on the clinical judgment and possibly the risk factor, and no less frequently than 2 to 3 months. Hepatitis B or C serology, HIV, varicella serology, and tuberculosis testing may be considered in population at risk of infection. Pre-treatment fibroscan or liver biopsy is rarely necessary, but may be considered if there is existing liver disease or high risk of liver disease. So it is better to avoid methotrexate in all such patients because we have many other drugs that can be prescribed for psoriasis and also in other indications, which are less toxic to the liver. P3NP collagen testing. In some regions, blood tests measuring type 3 procollagen amino terminal propeptide, uh, which is P3NP collagen, may be requested in adults aged 20 to 70 years before treatment with methotrexate and repeated every 3 to 6 months while on methotrexate. The P3NP collagen measures are used to assess hepatic fibrosis. In patients with psoriasis and on long-term methotrexate, 3 elevated levels over 1 year period may indicate liver damage. And this will call for stopping the drug. The P3NP elevated levels are seen in other conditions like in myocardial infarction, in trauma, in hypertension, in liver diseases for other reasons, and in inflammatory arthritis. Transient elastography scan. This is a liver ultrasound. The scan using transient elastography, fibroscan, measures the stiffness of liver and may reveal fibrosis or cirrhosis. If the result is in normal range, it is very unlikely that methotrexate is causing liver fibrosis. That is, a normal scan is a negative predictor of liver damage. So, by the use of P3NP collagen testing and by this fibroscan, we can avoid a liver biopsy. But if the liver biopsy is indicated, then it is reported using the Roink classification. Class 1 is normal or mild fatty liver. Type 2 is more fatty changes and portal tract inflammation. Type 3 is fibrosis and type 4 is cirrhosis. Chest X-ray is usually not done, especially if it is done 6 months previously. It is recommended in anyone with recent or past history of lung disease, and it is repeated should a patient develop some respiratory symptoms. Side effects of methotrexate. The first and foremost or the most common side effects are gastrointestinal, and the most common complaint is loss of appetite, nausea, and diarrhea. And it's seen in 1 in 12 patients, and the side effect is usually temporary. But changes in doses or supplemental folic acid tablets are helpful. Mouth ulcers and stomatitis is uncommon at the normal dermatological doses. Blood count abnormality. This is also very uncommon if methotrexate is given in dermatological doses with folic acid combination, but an overdose of methotrexate or deficiency in vitamin folic acid may result in anemia, leukopenia, and thrombocytopenia. Methotrexate should not be taken unless the blood count is normal or near normal prior to the next dose. Bone marrow failure can be induced by methotrexate. It is more common in elderly with significant renal impairment or concomitant administration of other antifolate drugs like trimethoprim or sulfonamide. When there is significant fall in cell count, methotrexate is immediately withdrawn and folinic acid therapy is initiated after discussing with rheumatologist or hematologist. Liver toxicity. Methotrexate is stored in liver, so transaminase liver enzyme level is raised for a few days after treatment, but they quickly return to normal. So it is best to do the test 5 days after taking the dose or just before the next dose. Long-term therapy is associated with scarring, fibrosis, or cirrhosis. This is more common due to other reasons like fatty liver, diabetes, hyperlipidemia, obesity, metabolic syndrome, and can also be because of viral hepatitis and alcohol overuse. So if you are giving methotrexate to any such patient, then you should be more vigilant in testing the liver enzymes and doing P3NP collagen scan or fibroscan. Lung diseases. Methotrexate rarely causes lung reaction, similar to pneumonia called as acute pneumonitis or interstitial pneumonia. The symptoms are fever, cough, which is dry and hacking, and shortness of breath. Chest X-ray reveal diffuse white patches. There is slowly progressive lung fibrosis or bronchiolitis obliterans with methotrexate, but it is rare. Eosinophilic pneumonia is also reported. Serious infections. It's uncommon that methotrexate result in reactivation of tuberculosis or opportunistic bacterial, fungal, or viral infections like herpes zoster or herpes simplex. It is unwise to take methotrexate if patient is already immunocompromised or is suffering from HIV. Cutaneous side effects. Methotrexate may rarely cause photosensitivity. It may result in ulceration of the skin and mucous membrane, especially in case of overdose. There can be diffuse hair loss, which is uncommon in dermatological doses, but it is common in methotrexate overdose. Other side effects include headache, dizziness, fatigue, mood change, especially when first starting on methotrexate. Nausea, confusion, and headache may rarely be due to hyponatremia, sodium imbalance. Actions to be taken in case of deranged laboratory tests. Please note that in addition to low absolute values of hematological indices, a rapid fall or consistent downward trend in any value should prompt caution and extra vigilance. So if WBC count falls to 3.5 or neutrophils less than 2, platelet to less than 150, ALT or AST twice upper limit of reference range, albumin unexplained fall, withhold the drug and discuss with the medical specialist. If there is a rash, oral ulcer, nausea, vomiting, diarrhea, withhold until the symptoms resolve. When there is increased dyspnea or dry cough, withhold and discuss with a pulmonologist or a medical specialist. Mean corpuscular volume increases to 105 femoliter, withhold and check vitamin B12 and folate, and discuss with hematologist if necessary. Mild to moderate renal impairment, withhold and discuss it with a nephrologist. Severe sore throat, abnormal bruising, immediate full blood count, and withhold until the full blood count is available. Check the platelet levels. Patient receiving methotrexate should either stop or limit alcohol intake, as mentioned before. Vaccination. Vaccine, live or killed, may be less effective in those taking methotrexate, so it is best if you fully immunize the patient before starting methotrexate. If it is not possible, double dose of vaccine may be required. Killed vaccines are safe and are often advised to reduce the impact of infection. Arrange annual influenza vaccination. There is an ongoing debate as to the risks of live vaccine in patient taking methotrexate. We have to know some drug interactions with methotrexate because methotrexate is one of the very common drug which is prescribed in dermatology. So the antibiotics containing trimethoprim and sulfonamides are also reduce folic acid. So if taken concurrently with methotrexate, result in methotrexate toxicity. Penicillin, minocycline, and ciprofloxacin should also be not combined with methotrexate. Use alternate antibiotics like clarithromycin or linezolid whenever you are giving antibiotics along with methotrexate. Aspirin and other NSAIDs reduce methotrexate eliminated by kidney and can result in toxic buildup of the drug. Alternatively, you should take paracetamol. But this drug should not be taken excessively because paracetamol itself may cause liver damage. Other drugs that may increase methotrexate toxicity include barbiturate, proton pump inhibitors, colchicine, diparacetamol, and phenytoin. Overdose. If accidental overdose occur, folinic acid injections or oral tablets may be necessary. The antidote should be given as early as possible. For high-dose methotrexate, there's folinic acid or leucovorin rescue. The dose is typically 15 mg orally, intramuscular or intravenous, every 6 hours for 10 doses. The maximum oral dose is 25 milligram. So this brings to end of the talk. I hope that this brief talk would help you prescribing methotrexate and monitoring your patients more vigilantly and carefully. Thank you very much for patient listening. See you next time with some other talk. Goodbye and have a good day.